All right. Good afternoon, everyone. Thank you for joining us today. My name is Abby Hunt, and I'm the Executive Director at Healthcare Education and Training, or we call ourselves HCT. If you're new to us, our mission is to provide comprehensive program development, education, and training to improve reproductive and sexual health outcomes, especially in the Midwest. We're so excited to spend the next 45 minutes with you today learning all about hot flashes. This is our second webinar in our four-part series focused on menopause. And when I say menopause, I want to clarify I'm including perimenopause and all of the associated phrases that you have heard along with this. We do have 2 more webinars, so if you have your email, we'll send them to you. We'll also be sending you a recording of this. We'll dig right in. A little bit of housekeeping. So if you need subtitles, you can see on this slide where you will find them. If you would like to ask a question, just please click on the Q&A button. We will most likely do most of our questions at the end to kind of keep things rolling. You can follow us. We are a little bit limited in our social media right now intentionally, but these are our sites, so you can find us more about us there. We would love to have your input, so please fill out an evaluation. It really does help us. We use it in real time. We use your feedback to guide how we do things, how we can do things better, what things worked really well. There's the email if you need help, technically. We'll provide this again at the end, but here is your QR code. You will also have these slides afterwards. Here's your QR code for an evaluation. Easy way to get there. If you are a nurse and you would like to receive nursing contact hours, this is what you need to do. Some disclosures, I'll pause for just a brief moment so that you can read these. We are an approved provider of nursing contact hours. And now I am so excited to introduce you to our speaker for today. Janet Carpenter. Some of you met her the last time, and we're so glad that you're back, Janet, so thank you for being here. A brief intro for her. She's a menopause scientist whose research has improved the understanding of hot flashes and palpitations. She's developed new ways to measure hot flashes and provided clear evidence on how to manage them. She has very many honors, and we're so lucky to have her here in Indiana at the IU School of Nursing. She has been named the USA Today Women of the Century in Indiana, Indiana Women of Achievement, Council for the Advancement of Nursing Science, Outstanding Nurse Science, Fellow of the American Academy of Nursing, and Sigma International Nurse Researcher Hall of Fame. Currently, Dr. Carpenter is the interim dean and a distinguished professor, and the Audrey Giesel Endowed Chair of Innovation at the Indiana School of Nursing across all of our campuses, so Bloomington, Fort Wayne, and Indianapolis. So, Janet, I'm going to turn it over to you now. Thank you for being here.
Thank you so much, Abby. I'm so happy to be here to talk with everybody about hot flashes. You'll hear me talk about hot flashes, night sweats, and VMS or vasomotor symptoms. I'll have some resources on a final slide for you at the end of the webinar. You can advance, Abby, there you go. And we're going to talk today about some basic facts about hot flashes, cultural differences in experiencing hot flashes, hot flash treatments. I know you're all interested in that. And then ways you can support women with hot flashes. So some basic facts about hot flashes is these have likely been happening for tens of thousands of years, right? As long as women who lived long enough into their post-reproductive years, probably having hot flashes. In the 1950s, women's life expectancy around the world got above age 50. And that's when we really started paying attention to menopause. Currently, it's believed that about 1 billion women worldwide have vasomotor symptoms or hot flashes, VMS, and 1 in 4 women will never have a hot flash. So I'm sorry if you're not one of those 1 in 4 women. And this is just giving you that global perspective of how we say hot flashes around the world. And my 2 favorites are vampata di calore, which is Italian for hot flash, and les bouffées de chaleur, which is French for hot flashes. So that's just some different ways. I have noticed a change in how medications are being marketed for hot flashes, and you hear more on commercials, vasomotor symptoms or VMS. So you will hear me talking about both hot flashes and VMS as the same thing. Okay, next slide. The interesting thing is that how you feel hot flashes on your body might vary a little bit. On the far right is women in USA and Europe. It looks like my header there got a little bit off, where women feel these hot flashes where the flowers are, really that chest and face. In Mexico, in the middle there, women feel on the back of their neck, they feel their hot flashes. And in Bangladesh, where a lot of women wear headscarves, they report feeling the hot flashes on the top of their heads. So when we think of sometimes healthcare providers will talk about a sudden rush of heat that starts in the chest and moves up, and that's not necessarily true for women. And I like to show women this because it makes you sort of think about your hot flashes. Where do they start? Where do they go? Where do they radiate? Where do they end up? So you can kind of keep track of that yourselves. This is my diagram of the menopause transition years, where you start premenopause, you're having your periods, into perimenopause. You go 1 year with no periods, and at that point we have a celebration and call you postmenopausal. And then the arrows here represent 3 different patterns of hot flashes. So some women have these persistent hot flashes that start right away in the late premenopause, early perimenopausal years, all the way into postmenopause. Other women really have them during perimenopause, and other women start them right around the time of their last menstrual period and then have them during postmenopause. So different patterns. So you might identify with one of these patterns or not. They usually last 8 to 10 years. So when we're talking about treatments, we're talking about finding a treatment that'll help for 8 to 10 years. They do disrupt sleep, mood, and concentration. 3 out of 4 women with vasomotor symptoms have sleep problems, and they have this additive or multiplying effect on quality of life. So, hot flashes can disrupt your sleep, and then the sleep disruptions themselves can disrupt your sleep. And if you have difficulty concentrating, you get anxious and worried about that, that can disrupt your sleep. So they all sort of feed on one another and can affect quality of life. In the past, I have a colleague who actually wrote a paper about the historical context of hot flashes. And what she found out is that in the past, they were really trivialized by healthcare providers. They were just sort of dismissed. Women were made fun of. They were thought to be due to emotional instability, even insanity. They were blamed as being responsible for broken family relations. In the recent past, they've been seen as imagined, which means they're not real, they're ridiculed. They've been a taboo topic, I would say, until about the last 10 years. We still don't fully understand the cause of hot flashes, and there's this kind of widespread confusion among both healthcare providers and women and their partners about what they are, how to treat them, what's happening in the body. So when we look at our public images, we see a lot of really extreme negativity. And so again, this is one way that I think we sort of ridicule women with hot flashes. It's this extreme situation where most women are somewhere more in the middle with their hot flashes. Although some of you may resonate with those images, I don't know. These are scientific facts right here on this slide. Women are not well prepared for menopause. When you go through puberty, you attend class in grade school and you learn all about what it is to get a period and what it means and what's going to happen in your body. And we do not do the same thing for women at menopause. Our healthcare providers are often not very well educated to help with menopause. In medical degree programs, there's very limited content around menopause. And even in nurse practitioner programs, unless someone is a certified women's health nurse practitioner, and even then the amount of content around menopause can be somewhat slim. We also know that treatments don't fully work for all women, and many women will try multiple treatments before they find one that works for them. And that just sort of complicates things, right? To have these multiple attempts to find a treatment that works. This is something that I ponder. What I don't know, if there's life forms in other galaxies, do they have hot flashes? I don't know. But these are the kinds of things that I think about as a scientist, right? And I think about global warming and all kinds of things as it relates to hot flashes. So this is just a little bit of humor for you today. When we think about hot flash treatments, I think this is really, really important. There are 3 different categories of hot flash treatments. There are medications that are approved by the Food and Drug Administration, which is the federal agency that approves all drugs on the market currently. And there's a list there of those medications. The second bucket of medications is kind of other medications that we know through really well done research studies that they work to help hot flashes. And then there's some non-drug options, again, that we know through research work well. And I'm going to go through all of these. But our FDA medications are hormone therapy, which I'm not going to spend a lot of time on today. And then fezolinetant or Veoza, lots of commercials about that one right now. And paroxetine or Paxil, Brisdil is another name for those. So the FDA approved medications, the great thing about these is that they don't cause weight gain or sexual dysfunction at the doses that we use to treat VMS or hot flashes. With fezolinetant, you have to get regular blood draws so that you're checking for the functioning of your liver with fezolinetant, and you get those more frequently in the beginning when you start taking that drug, and then kind of taper off on those blood draws. They space them out more the longer that you're on the medication. Paroxetine can also improve mood, and all of these have been shown to improve sleep. So these in particular are really helpful for women that have both hot flashes and sleep disturbances. Another treatment that we use are SSRIs, or the selective serotonin reuptake inhibitors. These are medications like escitalopram or citalopram. They're usually used to improve mood and anxiety. When they're taken in bigger doses, they can take up to about 6 to 8 weeks to work to improve people's mood and anxiety. When we use them to treat hot flashes, we give them at much, much lower doses, and they usually start to work within about a week. So we're not quite sure how they're working, but they do seem to help reduce both the number of hot flashes that women have, as well as how severe the hot flashes are. Some of the side effects here are that they can cause nausea, dry mouth, dizziness, and headaches. If you stop them too quickly, you can have some difficulties, so you do have to taper off of these slowly. And they can cause something called serotonin syndrome, some movement difficulties. In extreme situations, they can even cause hallucinations, but these are extremely rare side effects with these. And usually these side effects are seen at the regular doses that are used for mood, not the smaller doses that we use for treating VMS. And then another class of medications are the gabapentinoids. A common one you might be familiar with is Neurontin. These medications are often used to treat nerve pain, and for some reason they work very well for VMS. It's a really wide dosing range. So the nice thing about this is we start off at really low doses, around 300 milligrams, and gradually increase to 900 milligrams, and we can go all the way up to 2,400 milligrams. And so rather than taking multiple pills, people just take bigger doses in a given pill. One of the difficulties with the gabapentinoids is that they can cause almost like a hangover kind of a feeling, where it's a dizziness, drowsiness, fatigue. The good thing about this medication is if a person can stay on the medication and through those side effects for the first week, they'll often feel like in the second week, those side effects improve and are much more tolerated. And this drug is usually given at night because of that dizziness and drowsiness. And very rarely, these can cause some mood changes or suicidal thoughts and behaviors. So again, something to be aware of and watch for. Other medications that are FDA approved that I have a question mark there because there's very few research studies that suggest that these might work, but we need some more research in this area. The medication is called oxybutynin. It's known as Aspire, Ditropan, Cantera. They're all similar medications. These are usually used for bladder issues. And one of the side effects that was noticed when they were used for bladder issues is that they were helping women's hot flashes. Some of the side effects they can cause are dry mouth. They can actually cause some urinary difficulties like urinary retention. They can cause constipation, and they can cause blurred vision, although that's usually worse at higher doses. In older adults, higher doses of these can be associated with some cognitive issues like difficulties with memory, attention, or overall thinking. And so if you are a woman who is having some memory difficulties around menopause, this may not be a good option for you. And then we have some non-drug options, and I'm going to spend a little bit more time on these because I want you to really understand what these are about. The first one is cognitive behavioral therapy. And so you would meet with a therapist, or there are some apps being developed where you can interact with an app, and it's really helping you reframe, cope better with your hot flashes, understand what's happening in your body with the hot flashes, and give you some kind of self-care things that you can do to take care of your hot flashes. The regular program of the cognitive behavioral therapy is about an hour for 8 weeks, and then there's some homework that you do outside of the sessions with the therapist. It can be a little bit difficult to find a therapist who knows how to use this and apply it. One of the issues with cognitive behavioral therapy is it can take weeks to take effect, and it really helps you cope with your hot flashes. So the number or the severity of the really the number of hot flashes might not change, but you'll feel like maybe they're less severe, or that you can manage them better, handle them a little bit better, cope with them better. Clinical hypnosis is something that is taught by a licensed psychologist. It can be done in person, over the telephone. There are some apps available for clinical hypnosis where you teach yourself to go into a very deep relaxation. And then there's some suggestions that are given to you. And for hot flashes, those suggestions are around coolness, cool thoughts. The interesting thing about hypnosis is that when we compare its effect to estrogen, it seems to work about the same. So it's very, very effective. And it reduces the number of hot flashes that you have. So it has some kind of a physiologic effect that we don't fully understand. And it reduces the number of hot flashes you have, and then obviously how severe you feel like those hot flashes are. And I have some, the app is called EVIA, EVIA, that can help you with the clinical hypnosis. And these have been studied in women without breast cancer as well as women with breast cancer. And they're good options for people that don't want to take medications at all, but are really looking for something that will help them out. Next slide, Abby. This is another one I'll spend a little bit of time on here. This is something called a stellate ganglion block. And I'm going to point to myself. It's right around in this area. It's a collection of nerve fibers. And what a physician usually, or even a nurse anesthetist, will inject an anesthetic into that block of nerves. And what it does is it prevents that sensation of flushing from happening. And so even though women are having hot flashes, they're not perceiving that heat. The sweating is a little bit lessened, and just that the overall feeling that you get, that rush and that flush of heat goes away with the stellate ganglion block. You can get bleeding, bruising, or infection related to the injection at that site. The relief from this really varies for people. And so it can be like 2 or 3 weeks to many months, as long as 6 months in some cases. So that makes it very unpredictable to use. And I'll give you an example of when this worked really well for someone. I had a patient who was in my research studies, And she had a lot of hot flashes. We put a little monitor on women and measure how many hot flashes they have. And she had 51 hot flashes in 24 hours. So, a little more than 2 hot flashes every hour, all day, all night long. And she had a beautiful dress, and she was going to be mother of the bride. And she was really, really worried about sweating through her beautiful dress and being in photos and, her hair being wet and matted and all those kinds of things. And so she had this done about a week before her daughter's wedding. And she had relief, she thought, for about 3.5 weeks. And so it got her through the stress of the rehearsal dinner and the wedding and all of those events that are tied with it. She just felt like she didn't have hot flashes. She was much more comfortable. She wasn't sweating. She wasn't disheveled. So that was one example of when this might work well for someone. Okay, next. A non-drug option could be weight loss. There is kind of some limited evidence that shows that women that have a lower body mass index or a lower weight seem to have fewer hot flashes, and also a small weight loss. So even a 5 or 10 pound weight loss can improve hot flashes. And they're beginning to look now at the GLP inhibitors, the injections that people are taking for weight loss, to see if that also will help hot flashes. No side effects here especially if you do weight loss through behavioral methods, and obviously overall health benefits to keeping your weight in check. So that is something to consider. Obviously not an option for women who are at a normal body mass index and a normal weight. We don't want you to get anorexic and lose more weight, right? That's not a good option. So for some women, this might be something that could help. I don't recommend herbal therapies. In Europe, they are licensed as medical products. In the USA, we sell them as food supplements. So we do not oversee them in the same way that they do in Europe. And the quality and the purity of these agents is often very variable. There are studies on black cohosh for vasomotor symptoms. We have some really good research that shows that it doesn't help VMS, but when you go to like a GNC store or any kind of nutritional supplement store, you will see a lot of remedies for menopause, hot flashes, and most of them contain black cohosh, which we know really doesn't work. We also have some really good research showing that it's commonly mislabeled. So the concentration that you're getting in the pill is actually less than what's listed on the label. There's also research showing that black cohosh can be contaminated with other herbals, toxins, or other ingredients. So this is just, you can't be sure what you're taking. They don't have the same purity as medications do in this country. And then another note about St. John's wort for depression or mood. It interferes with about 50% of prescription drugs that are on the market. So this is one that you have to be sure that you're talking to healthcare providers about, and make sure your healthcare provider knows and is looking up whether St. John's wort affects the particular prescription medication that you're on, because you want to be sure that you're not having some kind of herb drug interaction that's affecting other medications you might be taking. These are some examples of the remedies, as I said, that are available in GNC. This is, I think, an Amazon screenshot. Estroven, Remifemin, those have been around for a long time. And these are not tested. They're just unproven. They're marketed to you. I just cannot recommend these at all because we just don't have research on them. And the research that we have shows the black cohosh, which is often a main ingredient, just doesn't work. So how can we support women with hot flashes? I think one of the things, you can go to the next slide, Abby. One of the things we can do is, get information about treatments out there to them, but also can we engage people in a conversation? And these are just some opening lines that I think work really well as we're talking about menopause. I never assume that people want to talk about menopause. Many women don't. And when women talk with me about their concerns, I always ask, do you want to be heard, helped, or hugged? And not everyone wants your help. They might just prefer, a pat on the back or a little bit of support. And certainly asking, tell me more about it. I'm here for you, or I hear you, are good options to keep people talking about it and let them know that it's okay to talk about things. Next slide, Abby. Um, one of the things I'm really passionate about is getting women prepared to talk to a healthcare provider. And if you yourself or you have a friend who might be going through menopause, can you role play what it's like talking to your provider? Can you be the provider that puts up barriers and doesn't want to discuss certain things so that you or your friend can practice? How do you get around that? How do you navigate that? And how can you help each other prioritize what you want to talk about? In my last session, I talked about it's very easy to get overwhelmed with the number of things that you want to talk about with menopause. I'm sure that you have lots and lots of questions all at once. But when you go to that first provider visit, what are the top 2 things that you want to talk about? And focus that visit on the top 2 things. And sometimes that requires a conversation to even get to that point of what are my top 2 things that I'm most interested in. And then sometimes people need help finding a healthcare provider, and we'll give you a link to menopause.org, which is it used to be the North American Menopause Society. Now they're called the Menopause Society. And they're the only group in the world that creates a certification exam. So they have a whole training modules available for clinicians, and then they get a certification as a menopause certified provider. And we now have several in Indiana. About 10 years ago, we didn't have any at all. And now we have several. So we can show you how to look that up. Workplace considerations, I think, are really important. I think you need to be aware yourself of whether you're working when you're not feeling well, or maybe if you're a supervisor, women in the workplace who may not be feeling well. People often try and work when they're not feeling well because of menopause, or they miss work because they're not feeling well. And when hot flashes get really severe and sleep disturbances get really severe, people can have a difficult time, right? Maintaining that concentration at work and showing up for work. If you're someone who is a supervisor who's able to change policies at your workplace to help women with hot flashes, some of the things you can look at are time off policies, temperature regulation standards. How many of our offices actually have individual thermostats, or recognizing when one person in a hot office can be really miserable if they're menopausal, and another person in a cold office, can we get people switched around a little bit with offices? And is it office policy that you have fans, cold or warm compresses, or heaters available for people? Women with hot flashes, and you may feel this yourself, will often have that sudden rush of heat. But if you get very sweaty, you'll then sometimes get chilled. When I was having regular hot flashes, I would go back and forth, right? I was too hot and then I was too cold, too hot, too cold. I was never very comfortable. And so having a fan and a heater was really helpful. And so these are the kinds of things that you could think about in your workplace, what might be helpful. In the United Kingdom, they're about 10 years ahead of us, I think, here in the US. And they're developing national policies to help women stay in the workplace at menopause. Okay, next.
Thank you, Janet.
So
I'm going to jump in. Oh, go ahead. Go ahead.
Sure. Oh, I just wanted to say, so menopause.org is the place you can go to find information about the menopause certified practitioners. Womenshealth.gov/menopause is our federal government website on menopause. And then I have links to a couple videos that I produced as part of it was called the Hot Flashes Cool art exhibit. It was to teach women about hot flashes in different ways. So we have a video where a colleague of mine actually created some music so that you can hear hot flashes. You can see hot flashes with a thermal camera that we used, and then you can read more about the exhibit here on these YouTube links. And I am happy to take questions.
Yes, thank you so much, Janet. Megan, I'm going to turn it over to you and see what questions we have for Janet. And I'll leave this slide up while we're going through Q&A. So you
Sounds
all can see
good.
those links. You'll also have this PowerPoint after the presentation. So Megan, take it away.
Yep. While we wait for questions to come in, while people are thinking of them, it looks like Emily has their.
What is the dose of Paxil, she said. So paroxetine salt, 7.5 milligrams. You can go up to 10 milligrams. I think there's two different ways that it's supplied. The paroxetine salt comes as 7.5, but I think it's not a generic. And so many people will do the paroxetine, which is available in generic, in a 10 milligram dose.
Next question is, how long after postmenopause will hot flashes typically end?
So hot flashes usually last 8 to 10 years from when they start. So they start at different places for women. With that one slide that I showed you, they can start in perimenopause or in postmenopause. So depending on when they started for you, you can expect them to last 8 to 10 years. And some women will continue to have them. About 20% of women, so 1 in 5 women, will continue to have hot flashes into their 70s and 80s, but they're usually much more mild and they're much less frequent. So you're having a lot fewer of them.
Okay. Next question is it reasonable to expect treatment to completely eliminate hot flashes? I'm on a hormone therapy and they are much, much better, but still being woken up at 3 or 4 a.m. each night with a hot flash.
Yeah, I hear this a lot, that the treatments don't fully get rid of the hot flashes. And certainly the research shows that they don't fully get rid of the hot flashes. One of the things we haven't studied is using 2 treatments together. So we don't have any research on using, for example, adding Paxil or paroxetine to the hormone therapy that you're on. I think it's worthwhile to talk with your healthcare provider about that, if that might be a good option, or one of the non-medication options like cognitive behavioral therapy or clinical hypnosis might be good options for you to try there.
Wonderful. Thank you. I'm not seeing any more questions at the moment, but I'm sure some people will think of something and ask it. So while we wait for any last minute questions, the eval for this presentation is posted on the screen. So be sure to pop that open on your smartphone. It will also be sent out after this webinar in an email, so you don't have to, if you don't have the capability to do so on your phone, you'll be able to get it there.
We talked about fezolinetant or Veoza, and that medication, as I said, has a lot of new drug commercials that you see on television. That's for treating hot flashes, and it works. There's actually a chemical in the brain that it works on, and it helps to, I think of it as a medication that kind of calms down the brain's temperature control system and makes the hot flashes less frequent and that less intense. So it is sort of a unique medication. I think we're going to be seeing more of those medications in that same drug class from other drug makers. And we talked about getting blood drawn for liver function tests with that one. And they do monthly testing for 2 months, and then they do 3, 6, and 9 months. They do blood draws. So that first year you're on it, about 5 blood draws you would have to have done. We also talked about CBT for hot flashes, and some resources that you can find online are Talkspace, Better Health, Headway. Those are all online therapy providers. And you can ask specifically about help with hot flashes for those. And the apps aren't yet quite available for that. And then I also talked about the hypnosis. Evia is the app for the clinical hypnosis. There's also a book. So this research was done by Dr. Gary Elkins. He's in Texas at Baylor University, and he has a book that's called Relief from Hot Flashes, the Natural Drug-Free Program. And that book will actually teach you how to do that self-hypnosis yourself at home.
Thank you. I'm still not seeing any questions or comments come back into the chat or in the Q&A. I'll give it another couple of minutes just in case folks think of a question that they have before we wrap up today.
And while we're waiting, I'll just jump in and just say thank you so much, Janet, for being with us again. I told Janet before this webinar that I had a lot of real-time responses to the first webinar of people saying, oh my gosh, I changed my provider. Oh my, I made this appointment. So I think this is a timely topic and lots of people are affected by it. And so we're seeing a lot of, direct takeaways from these webinars, which makes me really happy. I want to make sure you all know that our third in our series, we're talking about menopause and sex. So it should be very fun. We'll talk about the impact of menopause and all the stages on your sexual and reproductive health. We're going to do that with Dr. Tracy Kurtzer. She's at the Northwestern Center for Sexual Medicine and Menopause. And that will be on March 24th because the days are the same with these 2 months. So we're looking forward to that third. We have your email, you'll receive the information. So we hope you can join for that. It will also be recorded and available, all three will. So Megan, if you aren't seeing any other questions.
There is one in, so I'll just ask that.
Yeah.
So other than physical discomfort from a hot flash, are there other reasons to treat them?
Oh, Nicole, that's an excellent question. The hot flashes are really interesting in that there's a whole group of things that happen in your body with the hot flash. And we know that hot flashes are associated with some long-term changes in women's brains. We don't know if treating the hot flashes prevents those changes from occurring. But there is some aging that happens in the brain with hot flashes. Hot flashes also seem to be a marker of heart disease for women later on, developing heart disease later on. So again, we're a little less clear if we get rid of the hot flashes, does it help prevent heart disease in women later on? Not quite sure about that, but we do see links between hot flashes and those other conditions. Brain health, heart health are the two big ones. Your heart usually races when you have a hot flash. You begin sweating, and it's a change in your nervous system. We have a balance between a sympathetic and a parasympathetic nervous system, and that balance between the two changes. It's like a stress response. Your body burns calories during hot flashes. I don't know why they don't make you thin, especially when you have a lot of them. But you do get this stress response, and you actually burn some sugar in your brain. And so they can be associated with almost like a low blood sugar response afterwards. So again, this real physiologic event that happens could have some long-term implications for heart health, brain health. We need more research to understand if we treat them, if we can prevent those problems from happening. I think the biggest reason to treat hot flashes is for women who have really severe sleep disturbances. Sleep is necessary for your survival. And when you don't sleep, it affects your immune functioning, your heart, all kinds of biological processes. And it can really lead to a lot of long-term health problems, inflammation. So if you are having hot flashes and not sleeping, you actually often won't believe how much better you feel once you treat those hot flashes and start sleeping well. Quieter group today. Abby, do you have any personal questions or situations you want to discuss?
No, just it's rough out there. So yes, I personally learn something new every time too. So I think my takeaway, Dr. Carpenter, is I think I should combine CBT, hypnosis, medication, and then just throw it to the wind and see what happens.
Try it all, right?
I'm joking, but no, lots of good information. Lots of good information. I see the questions that I hear in my personal groups of friends, that I see in other extended groups of people between, I would say, even 37 and older. I feel like a lot of those were put on the table today, and so I hope that people are finding some answers or some next steps anyway. Because
Yeah.
it does, you reiterated this, but it does feel like it's kind of a trial and error as you move through the different symptoms. And so it's nice to know that there's more attention being paid to it, and thus there are more providers who are paying attention to it and learning more about it, because we stop it and we kind of stop often talking about the changes that women experience post reproductive age often. So I'm just pleased that you're here and we're doing this. So we want to keep doing it.
Absolutely.
So
Really important.
yeah. Well, and go ahead.
Well, there's a question that came in about plant-based HRT. And so we talk about phytoestrogens, which are plant estrogens. Similar to other herbals, we don't have much very good research proof that they really make any differences at all. Again, I don't recommend them. I really don't recommend anything that you would buy in a herbal shop or a store like GNC. They're just not going to be proven evidence-based things, and they're often very expensive, more expensive than a prescription medication would be.
I did think of a question, and it's not even a question, it's just a hot topic.
Okay.
So can you say anything about testosterone pellets?
I can. I have a lot to say about testosterone pellets, actually.
All right, let's do it.
And sometimes they're just called pellets that are implanted under the skin. They, are in for a while, a couple months usually. Women typically feel fantastic when they first start using them because they contain testosterone. They also contain estrogen and progesterone. One of the problems with the pellets is that after several months, women get too much testosterone. In some cases, I have heard from physicians that women are getting as much testosterone as women who are trying to transgender from women to men get. So they have hair loss, they have facial hair that develops, their voice deepens, right? It's those kinds of changes that are happening. And there's even changes like to the clitoris and the labia. There's a thickening that happens, and that doesn't necessarily go away. And so the pellets can actually be quite dangerous. There's a market out there which has resulted in people that aren't quite don't really have the right credentials to be providing them. For example, in one state, there was an ER physician who had left the emergency room and was providing pellets to women at menopause and really didn't have the training to do that. So stay away from pellets, please. The physicians are trying to get them like completely stopped because they really feel like they're dangerous to women.
Thank you.
Yeah.
Thank you. I was trying to think of what else have I heard. No, that's the main one that I've heard a lot about recently. So
I think when we think about the antidepressants, I hear a lot from women who say, my physician wanted to put me on an antidepressant and I'm not depressed. And so I think as healthcare providers, we're not doing a good job explaining to women that we're putting you on an antidepressant in a really low dose because it works for hot flashes, right? The dose that we give you for hot flashes might have some benefits for your mood, but it's nowhere near the doses that you would take if you were a depressed person. An example is venlafaxine is an SNRI, And that one, we give that in 37 milligram doses, 37.5 milligrams. And for depression, those doses are 4 times higher when used for treating depression. So great big difference in them.
Okay, well, we are right at 12:45. So again, our evaluation, please. That would be amazing. Look forward to our third webinar. And before we leave, another thank you to you, Dr. Carpenter and Megan. Anything I'm missing that we need to leave folks with who are joining?
Just one thing, for this menopause series, you do have to register for each individual webinar on its own separately. So if you register for one, you are not registered for all of them. Just so you know, for the next couple that come, you do have to register individually to receive information for them.
Great.
Thank
you
you
all
so
for
much for
joining
having
us.
me.
Thank you. Thank you, Dr. Carpenter. Thank you all for being here. Please come next time and we'll send you the recordings if you can't make it. Thank you. Have a good day.
Bye.